we are ready. Okay, so today we're going to start off by talking about seronegatives. So when it comes to seronegative arthritis, what are the types of arthritis we need to talk about? Pair. Okay, so psoriatic arthritis, A for ankylosing spondylitis, IBD,
Reactive.
R is for reactive. Okay, so let's go in that pattern, right? So when it comes to psoriatic arthritis, the important thing is the patients typically are going to have psoriasis, right? But do you always have to have psoriatic skin lesions in these patients? You don't. What is the most common psoriatic finding that you will actually have in these patients when they come with psoriatic arthritis? If it's not the skin finding, what is it?
Sacroiliitis?
No. It is nail pitting. That's going to be your key kicker that they're going to give you. The nail pitting is going to be present in most of your patients with psoriatic arthritis. But you can also have patients who are going to have psoriasis. Okay, skin lesions are going to be present, and along with that you're going to get arthritis. Now you can have multiple different types of arthritis with it, but the one they like to classically say is you're going to involve fingers or your toes, and you'll have something called dactylitis. Okay, it's not very often in rheumatology that I actually see dactylitis. So if you're starting to see dactylitis, think of psoriatic arthritis. Okay. Now, classic thing they would tell you, the finger would start looking like what? Sausage. You'll have a sausage finger is what the boards loves to go after that, right? Now, if you do an X-ray on those patients with the sausage digit, what would you see?
Pencil something.
Pencil in cup deformity. Okay, that's what your classic picture is going to be when it comes to psoriatic arthritis. Okay, now if anybody suddenly develops a lot of psoriasis everywhere, widespread, what should you test them for? HIV. HIV. If somebody's got HIV, you can have widespread psoriasis that breaks off immediately. Okay, so the way you're going to diagnose this is going to be essentially clinical for psoriatic arthritis. Okay, how are you going to treat them? And most of the time you're going to affect your small joints in your hands, right? So what's your treatment going to be?
NSAIDs?
NSAIDs is what you'll use. Topical or oral?
Oral.
Always whenever you can find areas where you can rub it on, go topical first. So you can do topical, but you can also do oral NSAIDs. What else can you use? Steroids also you can use. Now, if patients have really bad psoriatic arthritis, then you could actually use some other drugs as well. Okay, you could use methotrexate, you can use sulfasalazine. Okay, you can also sometimes use anti-TNF drugs here, but I don't think they're going to go into so much on treatment for that. Here you need to know about using NSAIDs and being able to diagnose it. That's what's important for psoriatic arthritis. Okay, now let's go to ankylosing spondylitis. Who gets ankylosing spondylitis? Say you got an X-ray, but the X-ray is negative, but you still have suspicion for it. What do you do then? Sacroiliitis is just the beginning of the problem, right? Then what else happens?
Eye findings.
Before that, let's just go for the spine. You're going to start having this problem spread all the way up. You're going to end up with something called bamboo spine, right? So basically your spine is going to kind of get fused, okay? Whenever your spine gets fused, as a person, what kind of position would they start getting? Are they going to be more lordosis or more kyphosis? You can end up with something called a restrictive lung disease, but it's not a lung pathology. Okay, so if you did your FEV1 over FVC ratio, which is the way to identify is it obstructive versus restrictive, here it'll be greater, right? FEV1 over FVC ratio will be greater than 70, indicative of a restrictive pattern. But if you do a DLCO, which is the diffusion of carbon monoxide, what would that be? Normal, because your lung is completely fine. It's a restrictive pathology just because of the fusion of the thoracic spine, right? Okay, so this is basically the problem that's going to happen to your spine. But can you have extra articular problems with ankylosing spondylitis? It is fantastic. If NSAIDs actually don't work, should you question the diagnosis? You should. Ankylosing spondylitis is probably one of the conditions that responds most to NSAIDs. So NSAIDs, does it have a drug disease modifying effect? It actually does. Continuous use of NSAIDs actually has a disease modifying effect. What NSAID can you use? That's ankylosing spondylitis. Next, let's go to Inflammatory bowel disease. So inflammatory bowel disease is pretty straightforward. If somebody's got inflammatory bowel disease such as ulcerative colitis or Crohn's disease, along with that, if you actually do have an arthritis, then you think about inflammatory bowel disease associated arthritis. So that's going to be your kicker. Can affect a lot of small joints, but some big joints also can get affected. Okay. The important thing is treatment. How do you treat it? Lastly, we are going to have reactive arthritis, which is also previously called Reiter's syndrome. Okay, this is the one we used to say can see, can pee, can climb a tree. Typically, the way it happens is you're going to either have a urinary tract infection or you're going to have a GI infection. So either a GI or a GU infection. What are the types of GI infection that causes reactive arthritis? When you look at reactive arthritis, this also can cause Achilles tendinitis. The two that really likes to cause Achilles tendinitis, one is reactive and one is going to be your ankylosing spondylitis. What is the treatment here?
For
reactive arthritis.
NSAIDs?
Because it's an infection that started the whole process, right? So should we treat the infection? Now, normally, with reactive arthritis, what else can you also have as a skin finding? You can have the patient's palms basically peel off skin. What is that called? They might even give you a picture. Keratoderma blemeragicum. That's what you want to see. And then thank you for watching. If you like our content, please like this video, subscribe to our channel, and hit the bell icon so you get notified when a video is released every week. Have fun studying. We'll see you on the next one.